Today we are discussing spinal robotic surgery as written in the New Humans and Wind Neurological Surgery book by Joshua T. Wewell and Juan S. Uribe. First, a brief history. In 1891, the first instrumentation was that of wiring done by Hadra. In 1949, the first pedicle screw placement was done by Michel and Kruger. It wasn't until almost 40 years later when a percutaneous pedicle screw was placed by Magro. Also in the same year, the first intraoperative imaging was used in neurosurgery. This was done with sonography. In 1995, the first intraoperative navigation was done by Polak to assess a C2 lesion. Further history, robotic surgery was originally intended for military use via remote telesurgery. The idea was to have surgeons localized in the United States and remotely operate on those in the battlefield. In 1987, the Programmable Universal Machine for Assembly, PUMA, made the Mark II robotic system. This was made by Unimation and was coupled with a CT-based stereotactic coordinates to perform a brain biopsy. This was the first robotic surgery performed, and it was done by neurosurgery for a brain biopsy. In 1997, 10 years later, the Da Vinci machine was produced and first used for a cholecystectomy, as produced by Intuitive. Robotics and spine surgery. There is a huge surgeon preference of intraoperative imaging and/or merging preoperative imaging to a navigation platform. Numerous systems exist and are available for the neurosurgeon and spine surgeon. Source data obtained from the imaging is then linked with a reference marker and can be associated with the patient. Navigated instruments are essential and can be used to place instrumentation. Robotic systems require pre-planning of pedicle screw entry points and trajectory. This is the major difference from traditional intraoperative navigation techniques. Current systems pair a navigation platform and a robotic arm that sets the trajectory for a pedicle screw. The first spinal robot was produced by Mazor Robotics and was tagged the Mazor Renaissance. This was done in 2011. Shortly after, in 2018, Excelsius GPS was produced by Globus Medical. This set the stage for robotics and spine surgery. Here is a preoperative snapshot of the screen for the Excelsius GPS. As you can see in the top left corner, there is a silhouette of a screw and its intended trajectory in both a sagittal and in the top right corner, axial views. A synthetic view in the bottom left corner shows what a trajectory of a screw would look like, and also in the coronal plane in the bottom right corner. Applications of surgical robotics and spine surgery. The applications are numerous. They include C1-2 fusion, arthrodesis, posterior thoracolumbar instrumentation, decompression, use in infection, MIS interventions, revision, degenerative diseases, osteotomies, anterior, posterior, and can be combined with many different platforms. Here is Dr. Uribe using the Excelsius GPS system, scrubbed out after an intraoperative CT scan planning the screws. You can see the set trajectory of the pre-planned screws, the robotic arm movement. A marker is placed through the robotic arm to mark the skin incision. Shortly after this, a percutaneous stab wound is made and fascial dissection is carried out. It is then that the screw is brought in and introduced into the pedicle and vertebral body. Postoperative images are shown with adequate screw placement. Robots in intraoperative navigation provide real-time information for the surgeon. This malplaced screw can easily be identified and adjusted to an adequately placed screw. Here is an adequately placed screw that can be identified using the robotics platform as well as intraoperative imaging. This is a screenshot of pre-planned screws with their entry point and trajectory superimposed on actual screw positions after they are placed. This real-time information allows the surgeon to provide the best placed screws possible. There are many limitations of robotics in spine surgery, particularly at its relative infancy. There is a steep learning curve through the first several cases of using any robotic system. The robot does add an additional layer to the workflow, which can be manipulated and improved upon on a surgeon-to-surgeon basis. Pre-planning of the screws and entry points is necessary. In many systems, this can be done based on a preoperative high-definition CT scan that is then linked to intraoperative fluoroscopy and then the robotic navigation system. However, some surgeons prefer to do the pre-planning while in the operating room based on intraoperative imaging alone. Once a trajectory is chosen, it cannot be manipulated during the passage of the pedicle screw. This is compared to traditional navigated techniques with navigated instruments where the trajectory can be altered throughout the passage of the pedicle screw. Future directions are numerous. Workflow optimization for spinal robotic surgery is key. The surgeon needs to choose a planned path with pedicle screw planning. This can be done preoperatively based on CT imaging or intraoperatively. Pedicle screw accuracy has been established to be very high with robots. However, there is still room for improvement. The use of image analysis in predicting soft tissue distortion is key, particularly in obese patients. Multi-center studies are currently in process and will continue to provide data for future studies. Applications beyond pedicle screw placement have also been discussed, those being bone work as well as interbody placement. Robotic guidance provides for accurate screw placement in the majority of cases. However, there are caveats to the robot, and this must be understood by the spine surgeon. You must understand the platform you are working with thoroughly before attempting a robot case. Also to keep in mind, robotic spinal surgery is still in the infancy. There's a steep learning curve that has much to be improved upon. Focus will be on optimizing surgical workflow and reducing error.